Hi friends, I'm back. Today we'll look at the other aspect of endometriosis, that is pain. Yesterday I was talking to you about the infertility management, which is a big concern for married and those who are desiring to have a child. But pain is one which bothers everyone, whether it is adolescent girl to young lady to elderly lady. So let's look at that. As you all know that I am teaching now at Sikkim Manipal Institute of Medical Sciences, obstetrics to all the postgraduates in India. Saint Augustine said the greatest evil is physical pain. Of course, everybody agrees with him. But a patient with endometriosis says, I would do anything for relief of pain. The standard care for pain, surgery plus medicine. Yesterday I was talking, the general management of any problem is surgery plus medicine. But when it came to infertility, it was surgery plus assisted reproductive techniques. But as far as pain, now medical management has a bigger role compared to surgery. But yesterday it was opposite. There was hardly any role for medical end of management of endometriosis, other than, of course, ovulation-inducing agents. The Practice Committee of American Society for Reproductive Medicine came out with this very important sentence: endometriosis is a chronic disease that requires lifelong management with the goal of maximizing medical treatment and avoiding repeated surgery. What are the principles of treatment? The decisions are individualized and consider clinical presentation and severity of symptoms. Obviously, location and extent. This is very, very important, especially if it is a deep-seated endometriosis. The relief of pain becomes that much more difficult. Age and reproductive desires. Suppose along with pain, if a person wants to have children, then the management slightly differs. Surgical complications complicate the whole issue. Then there are medical side effects with medicine. Finally, everything boils down to cost, whether it is surgical management or medical management. Cost is a big factor. But one good thing about endometriosis is that unlike other chronic diseases like diabetes and hypertension, which are there for lifetime, endometriosis is definitely relieved after attaining menopause. So somehow we have to deal with this for a span of 30 years almost. The problems with surgery are recurrence, and once you do repeated surgeries, there will be more difficulty and more complications, and you require an expert. There is lack of expertise, and the cost also increases exponentially. As far as medicine is concerned, there is failure to respond, or there can be poor response, or the patient may have just a temporary relief. The moment she stops the drug, the pain comes back. And you cannot use these drugs on a long-term basis because of its side effects. There are undesirable side effects sometimes which will make the patient stop the medications altogether. That's why there will be non-compliance, and there will be use of more of off-label drugs. There are a whole lot of off-label drugs that are used for endometriosis. Today, let us see what is okay, what is not okay, as far as ESHRE guidelines, February 2022. Before I go into the management, let us first understand the mechanisms of pain. Only then will we understand what should be used. There are mainly three types of pain. Number one is nociceptive pain. It is in response to noxious stimulus. What is the noxious stimulus in endometriosis? The chocolate cyst itself. or the endometriotic patches itself. Number 2 is inflammatory type of pain. It is in response to tissue injury and resulting inflammatory process. I used to teach undergraduates that there are only 4 problems in gynecology. Number 1 is the congenital problem. Number 2 is acquired or inflammatory problem. Number 3 is neoplasia, benign or malignant. And 4, when you have nothing, it is functional problem. Of course, pregnancy-related problems are a separate category in obstetrics. But in gynecology, these are the 4 main problems. But then the students would ask, so where would you place endometriosis? Whether it is malignancy, that is neoplasia, or whether it is acquired inflammatory problem, or whether it is congenital problem. Of course, it's not congenital. So it is inflammatory. It's an inflammatory problem. So there is a whole lot of inflammatory process that is going on, and that will give rise to pain. Neuropathic pain produced by damage to or dysfunction of the neurons. So these are the 3 main categories of pain, and we have to address sometimes one of them or 2 of them or all of them in a given individual. So does surgery relieve pain? Of course, surgical destruction or removal of endometriotic lesion significantly reduces the perception of clinical pain, especially the nociceptive pain. But there was incomplete relief of pain, proving that pain with endometriosis is not just nociceptive, but it involves inflammatory and neuropathic mechanisms as well. What is the role of prostaglandins? They are the mediators of inflammation. Directly activate nerve endings to the pain. They trigger the release of other analgesic mediators such as histamine, serotonin, NGF, and prostaglandins from other cells and afferent nerves. So they themselves activate the nerve endings to pain, plus they also trigger the release of other analgesic mediators like histamine, serotonin, NGF, and prostaglandins from other cells and afferent nerves. So they stimulate aromatase enzymes that favor continuous production of estradiol. So prostaglandins themselves do the harm, plus they stimulate the aromatase enzymes, which would convert the androgens into estrogens. What is the role of Cyclooxygenase Cox, what we say, is the rate-limiting enzyme that catalyzes the initial step in formation of prostaglandins from arachidonic acid. Now you see the connection. Prostaglandins are the pain mediators, whereas COX is the rate-limiting enzyme that catalyzes the initial step in the formation of prostaglandins from arachidonic acid. COX, especially COX-2, is induced by endometriosis and leads to higher levels of prostaglandins. So this COX-2 enzyme is induced by endometriosis, and that would catalyze the formation of prostaglandins, and prostaglandins are the pain mediators. COX-2 is now also stimulated by estradiol. Now you get the third one. So estradiol stimulates both endometriosis and COX-2. Endometriosis induces COX-2, and then COX-2 will help in the formation of prostaglandin. Prostaglandin will stimulate the aromatase enzyme. Aromatase enzyme will convert androgen into estrogen. So these 3 will have a circle that is called vicious circle. What is that? Prostaglandin E2 stimulates aromatase enzyme, which will increase the estradiol. Estradiol will stimulate the COX-2. Now COX-2 will catalyze the formation of prostaglandin E2. See the circle. And it is a vicious circle. It goes on and on and on. We have to break the circle. So how to break the circle? You have to use antiprostaglandins, that becomes the mainstay of management of pain. You have to antagonize the estradiol. That's the second main stay of treatment. And of course, COX-2, you have to give antagonism to that. That will reduce the prostaglandins, and in turn, it will indirectly reduce the estradiol as well. So all the three we may have to give. Now my job becomes very easy when we understand the mechanisms of pain. The concept of medical management is basically to suppress estrogen. We have understood that what estrogen can do. It will induce COX-2. COX-2 will catalyze prostaglandin. Prostaglandin will again produce estradiol. So we have to suppress estrogen. We have to decrease the retrograde spill, which is one of the theories of production of endometriosis. I have not gone into that. There are many theories of the causation or formation of endometriosis. One of the main theories is retrograde menstruation. Then it can be hematogenous spread, lymphatic spread, or direct spread. And these are some of the mechanisms of endometriosis. So when you reduce the retrograde spill, automatically the further formation of the endometriosis will be decreased. You have to overcome the progesterone resistance, and you have to use anti-inflammatory agents because inflammation is the main cause of pain in endometriosis, other than nociceptive and neurogenic causes. Aromatase inhibition has to be done. Otherwise, there will be production of estrogens, and estrogen will give COX, COX will give prostaglandin, prostaglandin will give estrogen, and that will go on and on. Anti-angiogenic factors also are very important because this all concentration is going on that, because even malignancies nowadays, unless there is supply of blood to the malignant tissues or endometriosis, it will not flourish. So anti-angiogenic agents are also being used as the newer agents against endometriosis. Then, of course, immune modulation. Without talking about immunology, no class is complete. So the medical management is basically hormonal. We have to antagonize the estrogen, plus or minus non-hormonal treatment. So first I'll talk about hormonal treatment. It is aimed at suppression of lesions. When you cut off the estrogen supply, hopefully the endometriosis will not flourish. Best achieved by menstrual suppression also. So you have to not only suppress the endometriotic tissues outside the uterine cavity, that's what is called actually endometriosis. Also, you have to stop the menstruation or suppress the menstruation so that the fresh spray of menstrual endometrium will not be there. Choice of medical therapy should be individualized, weighing in potential adverse side effects, cost, and compliance. What has been the traditional concept? I still remember my MBBS teachers teaching me this. There are only two main methods: pseudo-pregnancy regime, that is mainly progesterones, and pseudo-menopausal regime, that is GnRH agonist and danazol. So either you create a situation like a pregnancy wherein there is a holiday for estrogen and progesterone is the leading hormone, and it continues probably during lactation. There is no menstruation during lactation, so there is no fresh spray. So you induce such a situation by giving progesterones, or during menopause, obviously, as I told you right in the beginning of my class, that endometriosis will just go off. So you create a pseudo-menopausal situation. But the danger here in creating a pseudo-menopausal regime is that you cannot sustain this for a long time in a young lady, because it will give rise to menopausal symptoms, and most dreaded one is the osteoporosis. So most of us go with the pseudo-pregnancy regime only, though it is not called so anymore. We simply say we are giving progestogens. Now, with respect to danazol, as you can notice here, I have put it in a lighter color, not black color. I have put it in a gray color. This was actually a novelty when I was undergraduate. I remember very well the teachers coming and telling a new drug has come, danazol and all that. It stayed for nearly 30-35 years, but now let us see what ESHRE tells about danazol and GnRH agonists. Of course, GnRH agonists are very powerful. They will do the down regulation of the pituitary and they will suppress the FSH and LH. That's why there will be suppression of the estrogen. But ESHRE February 2022 guidelines say that studies on GnRH antagonist treatments support their use as an additional, that means second line treatment option. So that is now coming up in a big way because antagonists are sort of immediately acting instead of like GnRH, which has to take some time to act. Danazol is no longer included in the recommendations. It has got a lot of problems. It basically causes a lot of postmenopausal symptoms. That's why danazol is not at all recommended anymore. Non-hormonal agents. NSAIDs are beneficial for pain relief and reduce the bleeding also when used concomitantly with COC pills. So you are giving COCs, that is hormonal treatment, and concomitant with that, if you give NSAIDs, it is definitely beneficial, especially mefenamic acid. If you use, it will be, it will take care of the pain part of it. And then also COCs, if you use, that will take care of the suppression of the estrogen as well as the menstruation. Pentoxifylline, another anti-inflammatory immunomodulator that has also shown some promise. So you can use that. Gabapentin, that is anti-epileptic, alone or in combination with amitriptyline antidepressant for neuropathic pain. Lots of options were there in the past regarding the neuropathic pain, including nerve ablations, which I'm going to talk a little later, and what does ESHRE say now about it. But right now, when we are talking about medical management, non-hormonal management, there are mainly three categories of drugs. One is NSAIDs, number two is pentoxifylline, which is also anti-inflammatory, and then gabapentin, which is for neuropathic pain. For mild to moderate pain now, we saw the drugs. Now let's see how we see or how we tackle the different types of pain. Mild to moderate pain with no endometriomas. Okay, so there's no obvious chocolate cyst or something like that to remove. NSAIDs, maybe, as I said, mefenamic acid or COX-2 inhibitors. These two can be used. So they will take care of inflammatory type of pain. Mefenamic acid is anti-prostaglandin, and COX-2 is inhibitors will stop the formation of prostaglandins. So because we saw that they are the ones who catalyze in the, they are the enzymes which catalyze the production of the prostaglandins from arachidonic acid. So one is directly anti-prostaglandin, other one is not allowing prostaglandins to be formed. So NSAIDs are very good. Continuous COC pills, instead of stopping them and asking for menstruation, nowadays we have OC pills which can be used for somewhere between 84 days, even sometimes more than that. Continuous COC pills, small dose COC pills are available. Progestins, medroxyprogesterone acetate injections can be given once in 3 months, or you can give it in the tablet form. Norethindrone has been most popular progesterone that we have used. Norethisterone also can be used. And the most favorite of everybody nowadays is Dynogest. So I have to dedicate one slide for Dynogest, otherwise everybody will be disappointed. So it is a very friendly drug for both endometriosis patients as well as to the treating physicians, 2 milligrams daily. It inhibits prostaglandin 2 production and aromatase. So again, I spent a lot of time in explaining to you how prostaglandins will encourage estrogen, estrogen encourages COX-2, COX-2 encourages prostaglandin formation, as well as aromatase enzymes are induced by the prostaglandins. So it is both PGE2 antagonist as well as aromatase antagonist. It inhibits angiogenesis. That is additional advantage. As I told you, there should not be any new vessel formation to feed or treat or to these endometriotic tissues. So it also inhibits vascular proliferation. It reduces endometriotic lesions. As I told you yesterday, some of them claim that the endometriotic cysts have totally disappeared. I have never seen one. Though probably I have not used it for more than 2 years or 2.5 years. People are saying that you can use it for 6 years continuously, nothing will happen. But I don't think anybody uses them for 6 years continuously. I have used 6 months, and then we stop for some time and then reuse for 6 months, like that. Sometimes we have given for 1 year continuously. But I have never seen an endometriotic tissue, endometriotic cyst totally disappear. It has shrunk, obviously, sometimes even up to 50%, but it doesn't go off totally. Effectively, it alleviates the pain and it improves the indices of quality of life. This I totally agree, because I remember at least 2 ladies who were so fed up with the pain. They were almost on the verge of, even they said, feel like, ending their lives themselves and all that. But after starting Dynagist, I could see the smile on their face after 3 months, and they came back to this life and they were so happy. Safe and tolerable. And as I said just now, it can be given up to 65 weeks. That's more than a year continuously. High rates of patient complaints. Patients do not have a lot of side effects with this Dynagist, so they are very happily accepting this. For severe pain, though, again with no endometriomas, you can use again NSAIDs, but you can add GnRH with add-back therapy. When you give GnRH, as I said, it will cause so severe suppression of the gonadotrophins that they will almost get into menopausal type of a situation. So you have to give back some amount of estrogen progesterone. That's it, called add-back therapy. Women whose pain does not respond to the above are offered laparoscopy. So first is always the medical end of management when there is no endometrioma, especially. But if it is not relieved, then maybe you have to offer laparoscopy. Maybe there are very bad adhesions or very deep-seated endometriomas, and then that may have to be removed. Hormonal treatment. What is the systematic review? Cochrane systematic review 2012 can reduce the pain when given at diagnosis. So if you give early, it will definitely help. Adverse effects are common, of course, with danazol. Nowadays, anyway, we are very, very sure that we don't have to give danazol. GnRH analog, I already told you, the problem is that of a postmenopausal situation, especially osteoporosis type of a situation. Luckily, it is reversible when you stop it. And DMPA, that also has got irregular cycles and things like that. OCPs are less effective than GnRH analog, but less likely to reduce BMD, bone marrow density. That's what I told you just now. Danazol and GnRH analog, both of them will cause so much of osteopenia and osteoporosis. Reduce pain and other symptoms when given for 6 months after conservative surgery. So hormones can be given before surgery as well as after surgery. That's what we used to do it. Sometimes we used to call it sandwich therapy. And but definitely post-surgery, it is going to be useful. What are the alternates to progestins? Ethinyl norgestrone is a synthetic steroid with mixed progesterone agonist and antagonist. Etonorgestrel implants. I have no idea about these 2 drugs. I've never used them. But levonorgestrel intrauterine devices are definitely useful. You may ask how it helps. It may reduce the amount of menstruation. So after all, the aim of any of the treatment is to almost stop the menstruation so that there is no retrograde menstruation and fresh spray for the endometriosis to flourish. So also maybe little bit of progesterone that is coming continuously over a period of 5 years, that will also suppress the existing ones as well. So I'm underlining that levonorgestrel intrauterine device. What about aromatase inhibitors? They are reserved for women with severe refractory type of endometriosis related pain, often used in combination with progestins. So progesterones definitely are somewhat like anti-estrogen, and aromatase inhibitors also will make sure that estrogen is not produced afresh. Disadvantages include, again, bone loss. Whenever estrogen is antagonized, there will be bone loss. Estrogen is very important for pushing the calcium into the bones, and that's why whenever there is lack of estrogen after menopause, there will be osteoporosis. What about Mifepristone? See, this Mifepristone is somehow trying to come everywhere, I remember very well when it came as a abortion efficient pill, and it was very, very difficult to get, especially in India. It was smuggled. It was like a black money, like a black drug it was. And then, of course, we used that for first trimester abortion. It became a legal drug. Then Mifepristone tried to came and suppress the fibroids because they said fibroids also have got progesterone receptors. So not only antagonizing the fibroids with other things, you can also give Mifepristone. But I personally have not seen much improvement with Mifepristone in fibroids. Yes, some amount of shrinking will happen. To tide over some time or to buy time, you can use Mifepristone. People started using Mifepristone in endometriosis also. But here, it doesn't really fit into the place because progesterone, yes, but anti-progesterone, 104 papers over 11 years were evaluated. That means so many people have used it. But the conclusion was difficult to judge whether Mifepristone is truly efficacious. So we have to fall back on ESHRE February 2022 guideline. What does ESHRE say? Any guesses? Anti-progestins are no longer included in recommendations. So my logic is now being upheld by ESHRE that giving anti-progesterone in fibroid may be okay because they said there are progesterone receptors which will also stimulate fibroid. But in endometriosis, you have to give progesterone actually, not anti-progesterones. Angiogenic inhibitors, yes, this has got a role. Endometriotic implants grow in ectopic locations with new blood supply. VEGF inhibitors. Remember VEGF about OHSS I told you? So that is the one which is causing havoc. So you have to give inhibitors of that. Dopamine agonists like cabergoline. There also we use cabergoline. Here also we use cabergoline, 0.5 mg. It has got anti-angiogenic and anti-neurogenic properties, especially effective in deep infiltrating endometriosis. So when you have tried so many things, then probably you can give cabergoline. Because I have seen surgeons doing fantastic surgery on deep infiltrating endometriosis. But the problem is these women will have very bad adhesions and they will have somehow again and again, they will develop these things. So probably you have to cut off the blood supply to this area. And that is well achieved by cabergoline. Endostatin, Angiogenic, rapamycin, doxycycline, and curcumin, that is our turmeric, they all have been used. They are supposed to be angiogenic inhibitors. Well, I don't have any personal experience with any of them. That is endostatins, Angiogenic, rapamycin, or doxycycline. I've never given them. Cabergoline, yes, we had started with cabergoline once a week. Immunomodulators. As I said, you cannot complete a talk without talking about immunomodulators nowadays. So altered immune function plays a major role in genesis of this endometriosis. Immunomodulators decrease the inflammatory response to the disease. So loxiribin, it stimulates NK cell activity. TNF-alpha inhibitors prevent release of TNF-alpha from macrophages. Again, I must admit that I have no personal experience in using them. They probably are experimental still. As I said, all these drugs help in very early stage. Interferons, again, association of immunosuppression and endometriosis has been recently established. Hence, interferon has come into vogue. 2 short regimes of human IFN alpha 2B reduce the size of experimental endometriosis in rats. Single intraperitoneal dose or 3 subcutaneous doses on alternate days also were given. Endometrioma treatment for pain. Endometrioma treatment for infertility, I told you yesterday, up to 5 centimeters, you ignore that. After that, only you have to tackle it. But for pain, let's see. Again, here also symptomatic and big. Big means again more than 5 centimeters need surgical removal. Cystectomy is the best. Drainage and coagulation of cyst wall is the next best. Only drainage is done If there is a dense sedation, you cannot really approach and you cannot really remove the cyst and things like that. Some people even try to do it from vaginal route because they do not want to repeat the surgeries. But that's not the best choice. Very, very rarely, USO, BSO, TH, TLH with BSO is also offered, especially in the elderly ladies, not in, of course, infertile patients. But how it works really is questionable unless you remove the ovaries. If you simply remove the uterus, because the problem is not inside the uterus. Adenomyosis, I can understand you can do TH. Whereas endometriosis, TH alone is not enough. Probably TH, BSO is done as a package. You can't, everything is so adherent to each other that probably you may have to remove everything together. That is the meaning of this, rather than just going for TH. So please don't answer this as the first answer, postgraduates and undergraduates, who, if you are listening to this. That's the last option. Very, very rarely. That's why I put it in bold. What does ESHRE say? Post-operative medical treatment may be beneficial towards pain management. Just now I said that. So after surgery, follow it up with some Progestins or GnRH for 3 or 4 injections, and support a recommendation to offer it in women not desiring immediate pregnancy. If they want pregnancy, as I said yesterday, after surgery, don't waste time. Straight away within 6 months, you have to think of giving fertility enhancing. Maybe a couple of months you can wait for the surgical benefits to take over. If they don't conceive, don't waste time. After 3 months, straight away go for fertility enhancing treatment, either IUI or IVF. Deep endometriosis. Expected management for asymptomatic women, because there's no point in messing up again, digging and trying to create problems there. If they have no pain, just leave them alone. For urinary or bowel symptoms, medical therapy with hormonal suppression is appropriate. As I told you, aromatase inhibitors can be used nowadays. Surgery is indicated for women with urethral or bowel obstruction. Of course, as I said, there are fantastic surgeons who do a very good job. Lesions of non-reproductive organs, such as appropriate treatment complications are treatment of complications is necessary. Non-reproductive organs could be even in the other places. Sometimes scar endometriosis also can give rise to a lot of pain. You have to excise the complete scar. Again, something like it's an extensive surgery, somewhat like what we do for cancerous. So go beyond the edges and remove everything. So scar endometriosis usually not respond to the medical management. So you have to do surgical management. Surgery for neuropathic pain. Presacral neurectomy, that is interrupting the sympathetic innervations to the uterus at the level of superior hypogastric plexus, was done. I'm using the word was done. Resection of the uterosacral ligaments was done. And also there was one more called LUNA, laser uterosacral nerve ablation. Of course, it does not diminish the pain in other areas of the pelvis. This was also done. But what does ESHRE say? ESHRE says now in 2022, LUNA, presacral neurectomy are no longer included in recommendations. Just manage with gabapentin and other amitriptyline and antidepressants. So also anti-adhesion agents. No point in giving them. Maybe cabergoline is better. So to summarize the ESHRE guidelines, pain management, shared decision making is important. NSAIDs and other analgesics should be used. First line COCs can be used. Second line GnRH agonist, even antagonist can be used. Whenever you use agonist, you have to give add-back therapy. Refractory pain, aromatase inhibitors in combination with the above, cabergoline also can be used. It is not at all recommended to use preoperative hormones now. Post-operative, yes. But there's no evidence for non-medical type of treatment for pain management. As far as surgery is concerned, cystectomy or CO2 vaporization, similar, they have got similar recurrence rate. Excision is better than ablation. Presacral neurectomy, only expert people can do it, but it is no longer recommended. DIE removal, again in the hands of experts only. TIH is better than subtotal plus or minus BSO, depending upon the age, of course, but it's not a cure. Remember that. Post-operative hormones can be used as adjunct. Not recommended are LUNA, drainage and coagulation of cysts. So alternative therapies, I don't know how far I can go depending upon the time. I'll just run through this alternative therapy for pain. I gave a 40-minute talk, but today I'm going to just run through that. So what are the things we have in alternative therapy? Ayurveda, yoga, especially this particular asana, what is called Supta Buddha Konasana. It can be done either in the lying position or in the sitting position. This is just a joke. And meditation, far away from the city or from the doctor, better for her as well as for the doctor maybe. Naturopathy, whatever you say, when you say naturopathy, patients will just grab that. And this one also, green tea in a green cup. I'm joking, but green tea may be helpful. Homeopathy, Reiki, just do like this and remove the pain, right? And Chinese herbal medicine, acupuncture, see how nicely she's smiling. And acupressure, cupping, this looks very ghastly, but she's still smiling. Stone therapy and chiropractic, massage. These are not aiming at endometriosis, but they're aiming at removal of pain. Aromatherapy, why not? Exercise will release endorphins. Tai Chi also releases endorphins. Low glycemic diet, dairy products. There are a whole lot of endometriosis diet books. Then this was our favorite when I was a PG, TENS therapy, transcutaneous electrical nerve stimulation therapy. So finally, standard of care for pain is surgery plus medicine, but time to redefine it, that probably you have to make it surgery, medicine, and alternative medicine, or say integrated therapy. What does it contain? Surgery, allopathic medicine, if doesn't work, Ayurveda, homeopathy, neuropathy, doesn't work, yoga, meditation, aroma, doesn't work, Chinese herb, low glycemic diet, dairy products, Tai Chi, acupuncture, and exercise. And finally come back to surgery. Anyway, you have to manage them for 30 years. So you have to try all of them and keep circulating them. So that is probably is the management of pain. Pain is inevitable, but suffering is optional as per Gautam Buddha. So sum and substance of what I said is there are two main issues, fertility and pain. Infertility, surgery plus art is the best choice. For pain, surgery and medicine is the best choice. For stage 1 and 2, there is impairment of ovarian, peritoneal, tubal, and endometrial function due to inflammatory response. Whereas stage 3 and 4 is there is additional disruption of anatomical factors. Better results are after first surgery, so it should be the best one. Aggressive surgery can jeopardize ovarian reserve. IVF is the best option, though has poor outcome in stage 3 and 4. Pain, nociceptive, inflammatory, neuropathic. Surgery is best to remove the nociceptive pain. Repeat surgeries do not improve the outcome. Medical management includes anti-inflammatory, hormonal, and gabapentin and amitriptyline. Luna has no role anymore. Thank you very much for your patient listening. I hope you had a good idea about infertility and pain management in endometriosis. I'll come with a new subject tomorrow. This is endometriosis month, not week. Yesterday I made a mistake. It's not week, it's a month. So I'm going to give a talk again on 9th in Manipal for the nursing students. Probably I will share the link with you all that time.